Every 21 seconds, someone dies from tuberculosis. That's not a statistic from the 1800s. That's happening right now, today. We're diving into the critical clinical features of TB that every medical student needs to know, especially if you're preparing for NEET PG or FMGE exams.
And it's crucial information because TB remains one of the leading infectious causes of death worldwide, killing about 1.5 million people in 2020 alone.
Let's start with the basics. What exactly should clinicians be looking for when it comes to TB symptoms?
Well, what's fascinating is that TB can be quite sneaky in its presentation. The onset is usually gradual, and the early symptoms are often mild enough that patients might ignore them.
Really? That seems dangerous.
Exactly. According to the CDC, the most common symptoms include fever, night sweats, weight loss, and loss of appetite. These are what we call the systemic symptoms that can occur with TB anywhere in the body.
Those sound pretty general, though. How do you distinguish TB from other conditions?
That's where the pulmonary symptoms become crucial. When TB affects the lungs, which is most common, you'll typically see a cough lasting 3 weeks or longer, sometimes with blood-streaked sputum.
Ah, that's more specific. Any other red flags?
Yes, chest pain and shortness of breath are also common. But here's something interesting. Did you know that TB used to be called consumption because of how it seemed to consume people from within?
That's actually fascinating. It really captures the wasting aspect of the disease.
Exactly. And speaking of wasting, weight loss is one of the most reliable indicators, especially when combined with other symptoms.
Let's talk about diagnosis. What's the current standard approach?
Well, according to recent guidelines, the diagnosis is definitively established by isolating Mycobacterium tuberculosis from a bodily secretion or tissue.
And how is that typically done?
The primary methods are sputum smear and culture, along with nucleic acid amplification tests when available. These are particularly important for pulmonary TB.
You know, this reminds me of some of the challenges we've seen with COVID-19 testing, the need for quick, accurate diagnostics.
That's an interesting parallel. Both diseases highlight the importance of robust diagnostic infrastructure.
Now, what about TB that occurs outside the lungs?
Extrapulmonary TB. According to recent CDC data, about 21% of TB cases in the United States had no pulmonary involvement at all.
That's higher than I would have expected.
Yes, and it can affect virtually any organ system. The lymph nodes are the most common extrapulmonary site.
How does that present differently?
Well, symptoms vary depending on the site involved. With lymph node TB, you might see painless, gradually enlarging lymph nodes.
And I imagine that makes diagnosis even trickier.
Absolutely. That's why it's crucial for medical students to remember that TB can mimic many other conditions.
Speaking of medical students, what are some high-yield points for the exams?
One key point is understanding that TB can be either latent or active. About 2 billion people worldwide have latent TB infection.
Wait, 2 billion? That's more than a quarter of the world's population.
Exactly. And about 5 to 10% of those with latent infection will develop active TB disease at some point in their lives if not treated.
How do you distinguish between latent and active TB?
The key difference is that people with latent TB have no symptoms and can't spread the infection to others. They'll have a positive TB test but normal chest X-ray.
And active TB is when symptoms appear?
Yes, and that's when the bacteria overcome the immune system and multiply. These patients are usually infectious and can spread the bacteria.
Let's talk about risk factors. Who should clinicians be especially vigilant about?
HIV is the most important risk factor. It's actually the most significant factor predisposing to TB infection and mortality, where both infections are prevalent.
That makes sense given the immune system involvement.
And here's something important for the exams. When treating HIV-positive patients newly diagnosed with TB, you start anti-TB treatment first, then add HIV treatment within 2-8 weeks.
Why the delay with HIV treatment?
It's to reduce the risk of immune reconstitution inflammatory syndrome, or IRIS. The exact timing depends on the CD4 count.
That's definitely a high-yield point for the exams.
Another crucial exam topic is understanding how TB spreads. It's almost exclusively through inhalation of airborne particles containing M. tuberculosis.
And these particles come from where exactly?
They're primarily dispersed through coughing, singing, and other forced respiratory maneuvers by people with active pulmonary TB.
Is there a threshold for how many bacteria need to be present to be infectious?
Yes, according to current research, the sputum needs to contain about 10,000 organisms per milliliter to be detectable by fluorescent microscopy.
That's quite specific. Any other numbers students should remember?
Yes, remember that after initial infection, about 5% of people will develop TB disease in the first 2 years, and another 5% later in life without treatment.
Let's talk about some of the less common presentations. Any interesting cases students should know about?
Well, one classic presentation that often appears in exams is Pott's disease, which is TB of the spine.
And how does that typically present?
Usually with back pain, neurological symptoms, and sometimes a visible deformity of the spine. It's particularly important in regions where TB is endemic.
What about TB meningitis? That seems particularly dangerous.
Absolutely. It's one of the most severe forms, presenting with headache, altered mental status, and sometimes cranial nerve palsies.
That sounds like it requires immediate intervention.
Yes, it's a medical emergency. Early recognition and treatment are crucial for preventing permanent neurological damage.
What's the most commonly missed presentation of TB?
Probably pleural TB. It can present similarly to other causes of pleural effusion, and sometimes the systemic symptoms are quite mild.
How do you confirm that diagnosis?
Usually through pleural fluid analysis and biopsy. The fluid typically shows lymphocyte predominance and high protein levels.
As we wrap up, what's the single most important thing for medical students to remember about TB diagnosis?
I'd say it's maintaining a high index of suspicion. TB can mimic many other diseases, and early symptoms can be subtle.
And that's particularly important given how treatable it is if caught early.
Exactly. TB is curable, but delayed diagnosis remains one of the biggest challenges in controlling the disease globally.
Well, that brings us to the end of today's episode of Copilot Podcasts. Remember, when it comes to TB, thinking of it early could save a life.
And for our medical student listeners, these aren't just exam facts. These are skills that will serve you throughout your career.
Thanks for joining us today. Keep those clinical eyes sharp and never underestimate the importance of a thorough history and physical exam.